So welcome everyone. I'm Patrick Vernon. I've been asked to chair this important event today, and we are looking at it's a conversation looking at the development of the new contact and trace service developed by the NHS, which has been jointly organised with Ubele Initiative. So I'd like to thank you. We've got a fair amount of people who have registered today in this programme. There's lots of questions I'm sure you'd like to ask. And it's really great that we've got a fantastic lineup of speakers. As before, I chair the Citizens Partnership for the Healthcare Investigation Branch, which is part of the NHS England, which looks at untoward incidents and investigations around systems failure in hospitals as well. So, and that we'll be developing our work in the months to come around engaging with communities. But as you know, I'm also a community activist involved in lots of stuff as well. And so this is really a fantastic event that we're having to really try and take forward some of the things to make sure that the impact of COVID-19 has a lesser impact and how we can improve healthcare services. We've got quite a few things happening today around this agenda. We are going to start off with a poll with a number of questions, and this is to help us to get your sense of what you know already about the new service. So if you could please complete the online survey as we speak, that would be really fantastic. So we've got 3 sets of questions, and if you can just follow the instructions and just cast your vote, please. Unfortunately, we don't have any interlude music, so just use your imagination. Okay, hopefully you would have done that by now. And by the way, just to let you know, we will be producing a conference report, so you'll get all the feedback from the polls that you've completed and some of the key messages that's come out of today's event as well. So hopefully you've done that so we can start the program. So as you can see, in terms of the question, how much do you know about the NHS Test and Trace service? People have heard of it, but obviously not enough information, and that's why we're here today. And obviously that is something that's useful for the team to know as we move forward as well. Okay, what's your current impression of the NHS Test and Trace service? Biggest response, it could be helpful to help reduce the spread of COVID-19 in the BAME community. And the second highest response, I don't think it'll help reduce the spread. I'd be interested to know how you people feel by the end of today's event. And then the next question, final question, is what your main areas of concern about this service. And with something that we've already been aware of about sharing personal data, having an app on your phone, that they seem to be the biggest concerns. Okay, let's move on, everyone. We're going to start with the proceedings. So it's really fantastic that we've got Baroness Dido Harding. She's the executive chair of NHS Test and Trace, and she will do a presentation to demystify the NHS Test and Trace service. So I'd like to warmly invite Baroness Harding, and there's about 140 of us so far, and more will be joining. Baroness, over to you.
Oh, thank you, Patrick. Dido, please.
Okay, Dido, sorry.
Thank you. Well, firstly, can I just thank you and Ibele and everyone for inviting me to speak and to listen to your discussion. I'm also very grateful. I'm being joined by a couple of my team, Raghuv Basin, who's my Chief of Staff, and Kerry Edwards, who's our Chief Customer Officer, are also going to be on this call and can help field questions, but more importantly, for all of us, all three of us, to listen. We are building a brand new national citizen service, and this is a really important step on our journey as an organisation. And so I'm really grateful to all of you in letting me come and learn, because if this is going to work, we need to build a service that is really going to work for everyone. And so it's important that we really hear your views and feedback as we design it. I've got a couple of slides, which I'm hoping someone is going to queue up for me. Brilliant. I thought just one slide, I just wanted to talk through what NHS Test and Trace aims to be. So our ambition is to build an integrated, world-class COVID-19 test and trace service. And the purpose of this is to control the virus and to enable as many of us as possible to get back to living a safer and more normal life. And the way we're thinking about it is these four circles. We will contain the virus by rapid testing at scale that allows us to identify anyone who has got the disease, get them the support they need, and make sure that they don't infect anyone else. Then by identifying anyone that they might have been close to that they could have potentially infected, that's really what tracing is, so that we can alert and support those people so that we break the chain of infection and enable those people to self-isolate and ensure they don't go on and infect anyone else. And then using the data and the insight from testing and tracing from other publicly available data sources, the idea is to spot flare-ups or outbreaks as they emerge, and then over time before they've even emerged, so that at a local level we can contain those outbreaks and stop them becoming a sort of a raging fire, and to make sure that we don't need to put the country back into a national lockdown, but instead you only have to have sort of small local action to stop the virus spreading. And then the fourth element, our enable workstream, as our scientific knowledge of the virus grows, we hope and expect to be able to then provide means for both individuals and organisations to ease the social and economic restrictions. So by knowing that you are not infectious. Now, at this stage, the testing doesn't enable us yet to do antibody testing, enables us to know that we have antibodies, not that we are not infectious. But over time, the science will improve, and then that should enable people who have had the disease and are no longer infectious and are increasingly immune, will be able to give you that personal information and give you more freedom as a result. So this is an organisation that we're building that's purpose is to give people back their freedom. But we will do it by asking a small number of us at any one point in time to stay at home in order to protect ourselves, our families, and our communities. And to make that work, it needs to be underpinned by huge public engagement and trust and participation. This will only work if 60 million people across the country trust it and believe in it, and we all change our behaviour. So if you go to the next slide, that means that making sure that we are building an NHS Test and Trace service that really meets the needs of our BAME community is huge, or communities, sorry, is hugely important. So we want to build a service that is accessible, that is trusted, and is equitable. And in doing that, we believe that's how we will increase engagement in all communities in the country. But we're particularly focused, as you know, the data as an analysis as published by Public Health England shows all too starkly how this disease doesn't treat everybody equally. And that it's really important that therefore our actions to contain the disease really are accessible, trusted and equitable for our Black and minority ethnic colleagues across the country. So on this slide, we've just tried to set out how we would like to do that. And I'd really welcome everyone's input and feedback on what we're missing and how we can do this better. So we need to understand, well, I say, first of all, we need to listen. So I will stop talking very quickly so that we can hear your views and insights, so that we can understand the barriers and the opportunities, so that we can co-design with communities, build an end-to-end service that actively addresses inequalities, recognises the inherent unfairness in our society today, and builds a system and a service that addresses that. We know that it means we need to build a genuinely diverse organisation, that we need to train our staff properly about racial inequality, the lived experience of our BME communities, and consistently and continually evaluate and improve. So that's the way we're thinking about how to do this. And this session today is a very important beginning for us in starting that journey of listening. So I think I should stop talking at that stage and hand over, if I can, to Johanna Rammstein. I think, Johanna, you're going to sort of try and kick off some of the questions, if that's okay.
Yeah, thank you for that, Dido. Yeah, just to remind everyone, because also there have been some questions about the poll. The poll is just a gauging people's impression, what they know about the service. We'll be doing another poll right towards the end of this event to also find out what you've learned and other questions as well. And it's just a poll. We're not going to capture your data to do for anything else. It's just a simple poll just to capture and monitor and see the level of people's awareness. Before I bring in Shaheen and other colleagues, just a quick question for you, Dido. What do you think are kind of the barriers or challenges you think facing any kind of new service, but particularly the service that you are launching ahead and leading now?
Well, I think one of the really big barriers that we face, I've sort of tried to allude to, is building both awareness and trust in the programme. So we've done quite a lot of polling, and we do know that people from BME communities are much less likely to know that they can be tested if they have symptoms of coronavirus, and have a much lower level of trust in the service. And actually, interestingly, just as we've seen on the poll, the Menti poll you've just done, particularly nervousness about sharing contacts. So I think, you know, the first step we've really got to work at is how we build a deeper understanding of what we need to change in order to reach people and earn that trust, which is why we wanted to be involved in the conversation today. We are recruiting people into Test and Trace who will have specific responsibility to deliver against these, but I'm really interested in getting people's advice and input into how we build awareness and trust within your communities. I think the second challenge for us is delivering testing in a way that's smarter so that we hunt out the virus. So, you know, we know that people from BME communities are more likely to be exposed to the virus from their work. So we've already introduced policies to offer additional testing for people at high risk of coming into contact with the virus in some settings, say, so for example, in care homes, but I think we need to work a lot harder at that. We're looking at how we extend those policies outside of healthcare settings and plan to announce the details of that very soon. So working out how we target testing and make it easy and available to people who are most likely to be at risk. And then understanding and managing the impacts of the test and trace policy. So we know that changes to guidelines of the guidelines for self-isolation will be difficult for many people. You know, we're asking people who've been in close contact with someone who's tested positive for COVID-19 to self-isolate for 14 days, even if you don't have symptoms yourself. And I do know that's very challenging for people, for both their physical health, for their mental health, and actually also for their financial situation. So we've taken some steps to address this. On mental health, councils across the country are developing services to meet local needs. The government announced £300 million of additional funding to support local community test and trace services. Financially, we've made statutory sick pay available to people who need to self-isolate, but I'd really like to hear more about what steps we could do that would make it easier and enable people to feel more supported when they're in isolation. And then I think the third one is to really make sure we learn how to ensure that we take the BME community's views into account in how we engage. So again, this is a new service we're building, so we have the opportunity to try and do some things right without having in the past done them wrong. So I'd really like to get input in how we make a very conscious effort to build in listening and learning with communities going forward. Those would be my sort of 4 big areas.
Okay, thanks so much for Dido, and I know that a lot of people have got quite a few questions in the chat that we'll deal with in the Q&A. At this stage, I'd like to invite Johanna Rammstein. She is the head of workforce transformation for South East region of NHS England and NHS Improvement, and she will make some comments regarding the service and her experiences of working in NHS for many years. Johanna?
Thank you. I hope you can hear me and see me. Yeah? Brilliant. Okay, so I'm Johanna Rammstein, as you say. Thank you for the introduction. I've worked in equality, diversity and inclusion for about 30 years. I think I was obviously a director of Positively Diverse and deputy director of delivering race equality and mental health. And recently I've taken up the role of head of workforce transformation. So the reason I'm here is because we know that COVID-19 is having a disproportionate impact on BME communities. And that's affecting my family, it's affecting my friends, it's affecting my community. Importantly, it's affecting our NHS workforce. 40% of our doctors, 20% of our nurses, and 17% of social care staff are from BME groups. And over the years, we've seen many reports talking about the inequalities. We've seen the Snowy White Peaks by Roger Klein, Macpherson, Rocky Bennett Inquiry, Race Disparity Audit, so many reports and papers telling us about the long-standing inequalities that we face. But this particular pandemic has actually heightened those inequalities that we've been facing for many years. So one of the reasons I wanted to be here today is I do think we have a real opportunity to influence this test and trace programme, because it could be a lever for reducing the risks of inequalities. The important point I want to make, though, is that the context is important. So test and trace alone won't make the difference. on its own, but if we, for workforce, if we look at test and trace alongside effective PPE, fit testing and robust risk assessments for staff, that's really important. And for populations, we have to think, and I know Dido, you touched on this, we have to think about the context of socio-economic inequalities and the fact that households, for example, Pakistani and Bangladeshi households, can be the ones more likely to be shut down. Their roles are more likely to be shut down as a result of COVID-19. So those inequalities are exacerbated. So for me, I'm looking forward to a dialogue and co-production with our communities. And my big question today, or one of the wishes for today, is that we really do ensure that BME communities' views are taken into account in the way we design and deliver the Test and Trace programme.
Thanks very much for that, Johanna. I'd just like to invite Raghu Basheen, who is Chief of Staff to Baroness Harding, and he'd like to make some observations too.
Thank you, Patrick. I just want to emphasise what Dido and Johanna have said. I mean, for me, this is exciting in being able to design a completely new public service, and I'm a career civil servant and have sort of had to almost work against the systems and structures that have been designed over the past couple of 100 years for how we do public services. And I think what we're doing now is thinking about actually what do the customers, consumers and individuals we serve need, and that's right across the span. And the opportunity that creating something new in this environment gives us to do things differently and have these sorts of conversations right at the start is really heartening for me. We are committed to, and we know the only way that we will succeed as a service and as a country is to make sure that the service can be accessed by everyone and is trusted by everyone. So bound in with our future success is working with colleagues like yourselves and others to make sure that we understand the needs of everyone in the country, wherever they are and whatever they need, and try to cater to those with what we're doing. So I'm really excited to be able to have this conversation right at the start of what we're doing. And I know that we will make some missteps along the way, and we've probably done some things that aren't ideal given the speed at which we've needed to operate. But what we're also doing is building an organisation that's continuously learning and improving, and we're able to make changes we want to make changes. So I'm excited to be here and looking forward to the conversation we're about to have.
Okay, thank you for that, Raghu. I'd like to invite Kerry Edwards. She's the Chief Customer Officer for the NHS Trace service.
Hi Patrick, hopefully you can hear me okay. Thank you very much for that introduction. Hi everyone. My role on the team is to bring about a level of systemic listening skills actually to make sure that we build and design our services based on the needs of everyone. And so my role on the team is to think about how we hear about those requirements, how we build them into our design, and then make sure that we can measure our performance against those promises. So that's my role for being here. And yeah, today is hugely important to me just to hear some of the most important and pressing requirements that we know that we need to adopt and take on board now.
Great, thanks very much. Now this is an opportunity for the audience to raise any questions. We've got quite a few questions in the chat, which I'll refer to. But if anyone wants to ask a question directly to the panel, I think my moderator will hopefully let me know who they are and I can call your name out. If not, I'm going to start with some of the questions that we've seen in the chat already. So here are some questions. So the question, this is one for Dido, but I'm sure your colleagues will answer this. Why does the data have to be kept for 20 years from the act? And what's the reasoning behind that?
I can pick that up in that this is just standard patient data protection. So if you have a test, that test now, the test result will now go onto your GP records and be held along with all your other health data and cannot be used in any way other than your other health data is for you personally.
Okay, great, thank you. We've got our first live question, and that is someone from Health Watch.
Can you hear me?
Yes, we can hear you.
Hello, hi. My name is Lizzie and I work for Health Watch Waltham Forest. I just wanted to ask a question. During the London Assembly, it was revealed that the app will not be able to do its function in crowded residential units, such as tower blocks, until at least autumn. Considering that BAME communities are more likely to live in crowded residential units, such as tower blocks, how do you plan to serve that community in both the Test and Trace program and beyond in this interim period?
Let me pick that up, and then maybe Kerry might want to add some more detail. I think the thing to start with is that the app is only a small portion of the Test and Trace service. I've been describing it as the cherry on the cake, not the cake itself. We are up and live with Test and Trace, but not with an app yet. So everybody who is getting a COVID test today and then going through the tracing process is either doing that electronically by ordering a test online, going and then physically getting their test, getting their result back through an email and a text message or a phone call. And then they're going through the contact tracing process, either by giving their contact details through an online form or through talking to one of our health professionals from our contact tracing team. And then people who are contacted are either being contacted electronically or they're being contacted on the phone. And all of that data then goes back into your GP, your test results. So at the moment, we don't have an app live across the country, and we do have a scaled test and trace service. That doesn't mean that I think we're reaching in enough into communities. And so I think we've got a lot of work to do to make it easier for people to get tested if they don't have a car, or if they're don't have smartphones, if English isn't their first language, if they're scared of the consequences of going through the process. So I think that I wouldn't like you to think that the app is the sort of secret weapon that makes all of this solvable. Actually, it's just one of the channels that will enable us to reach everyone. And I think across all of those channels, we've got to improve our outreach into communities.
Great.
Totally agree. I think that's probably our biggest task and challenge right now, is to think about the start of the process and how we listen to and engage with people that need us, and be able to have conversations and involve the process to the people that need it most, regardless of whether or not they have access to some of the means that maybe are what we're referring to here, like digital access or smartphone access. We still need to be able to make this system work for everybody. That is a priority.
Great, thanks for that. We've got quite a few questions in the chat. I'm going to go through some of them to bring to your attention to the panel. Question: tracers have not been told what to do if people don't speak English. Is this guidance on its way?
Now, as I understand it, there is guidance for contact tracers, and translation services are available for all. But just remember, we've launched this service very quickly and have a very large workforce. So it's entirely possible that we have more work to do in terms of training and supporting all our contact tracers so they understand the services that they can pull on.
Just to build on that, if I can, Patrick, so I think it's really important to think about different translations that are needed in terms of people with difficulties reading, or whether or not they are hard of hearing or with hearing impairments. So actually we've got to translate for lots of reasons. Dido's right, we are making and have made in the last few weeks some significant changes to make all of that capability in the tracing system available and translatable. But Dido's right, it's going to be an imperfect science when there are so many people to train, and I'm sure that there are examples where we haven't met the expectations in the last few weeks. Okay,
another question is, why would people from BAME backgrounds trust the service when recent reports or sites have been susceptible to COVID-19 because of racism and discrimination?
Gosh, that is just such a big and important question. And I think people will only trust our service if we behave appropriately and earn the right to be trusted. And I'll ask sort of Raghu Van Kerry to comment as well. I think that the first thing is that by us being humble enough to admit that there are extreme inequalities in this country, and we need to all play our part in trying to rectify that. And my heart goes out to anyone in the country who's lost loved ones as a result of COVID, but particularly to our BAME community who have been so much more hardly hit. But I think that those of us starting this service, I would just sort of encourage and implore you to help us make it work, because actually it's one of the ways that we really can protect our friends, our families, and our local communities if we work together to test and to trace and then to contain the virus. And it would be just so awful not to do that because we hadn't convinced people from the BAME communities that this was something that was in their power to shape. So Raghiv, what's your view?
Yeah, I mean, I completely concur with that. Until 6 weeks ago, when I joined the service, I worked in a hospital in Reading, and we could see the differential impact that COVID was having on our local population, from the people coming in our doors and the people in our intensive care and in our workforce. And our hospital was one of the first places to have an individual pass away. And it's really difficult that this virus seems to be affecting certain groups more than others, and we seem unable to be fully to understand that. What I would say is about the service that we're building is it is an NHS service in that, and it keeps to the principles of the NHS service. It does not discriminate between colour, creed, belief, or religion. This is a service for everyone, and in the same way as we've done in the NHS, and I know from my personal experience at our local hospital, we've worked with local communities to make sure that the service fits around their needs. We need to do the same for this national service. As Dido says, that's more challenging because we don't have years, months to do that. We've got days and weeks, and this is why this conversation is so important, to make sure we can make the changes that we need.
If I can come in here, Patrick, as well.
Sure, yes.
So just to echo what you were saying, Raghu, it's really important that communities, I've worked in co-production for many years, and patients and communities often know the answers. So it's important to get, I know you've had to pull them, but it's important to pull them together. It's absolutely important to include communities in the decisions that are made around test and trace, either via focus groups or engagement groups. And also, I think it's important to hear some of the uncomfortable feedback that we might be getting, because there's always a gap between our aspirations as an organisation and the reality of the service that's being delivered. So listen to the uncomfortable feedback that we might be receiving.
Right. There are a number of questions in the chat which focuses around data, and the questions, I'm just trying to summarise some of these questions. There's questions about the confidence in the data that's kept and gathered. There's a number of questions around Serco, who is the contractor who's managing this data, about how confident are you, especially with their recent track record where they've been fined for failing delivering government contracts. And there's questions to do with how does it relate to BAME communities in them feeling confident to share their data on the apps as well.
Shall I talk a little bit about our contact tracing workforce and how they divide up? So there are 3 tiers of our contact tracing teams. If you start, they're catchily called Tier 1, Tier 2 and Tier 3. If I start with Tier 2, so Tier 2 are clinical professionals who've been recruited for us by NHS professionals. And if you test positive, you will first speak to one of those clinical professionals who will talk you through, firstly, to make sure that you've got the clinical support that you need, but then who you've been in close contact with, and they will help guide you through identifying who your close contacts are. Then Tier 3 are the contact tracers who then those contacts are passed to, and they will, if you are the contact of somebody who's tested positive, you've been in close contact with, and you will receive a call from Tier 3. Our Tier 3 contact tracers are not clinically trained, and they've been recruited and are managed by 2 outsourced partners, Sitel and Serco. And then Tier 1, and the reason I've gone this order, is Tier 1 are our most specialised teams, who are local health protection teams in Public Health England. And we escalate anyone who is a positive case, who tests positive and works or lives in a complex environment, such as health and social care, in prisons or in schools. And those people's cases will be immediately escalated to tier 1. Sometimes a tier 2 contact tracer then escalates up contacts into tier 1 as well. And those are teams that are employed by local authorities and by Public Health England. Our workforce in tier 2 and 3 are roughly 20% non-white. Which is, sorry, actually, I've got the wrong number, 25%. So it's actually slightly higher than the representation of non-white communities in the NHS in England as a whole, which is, I think, circa 20%. And the prison service has a target of 14%. So the good news is that we have a very diverse team of contact tracers. I understand and hear some of the concerns about the brand of Serco, but they are a large and successful provider of services to the NHS, to a number of other services that support families across the country. And actually, I'm incredibly grateful to the 25,000 odd people who've signed up to be part of our contact tracing workforce, and pleased that they are representative. I don't actually have the data yet for the representation in tier 1, and as soon as I have, we will be publishing it.
I just want to bring in, if I could, Patrick, a question from further up in the chat that's related. I think the question was somebody called Holly, and I hope I've remembered your name correctly, Holly. It's way back. But Holly asked us about whether or not we can think about using local community outreach teams to extend our ecosystem, and to think about how we might reach some communities that otherwise we wouldn't be able to reach. And I think it plays into this conversation about how we think about ourselves as an ecosystem and our own mix. So Dido, it might just be worth us sharing there that is an intention. We know that we are part of an ecosystem, we're not the whole, and we need to work much harder. And I imagine today might give us some of those ideas actually about how we might do that, Patrick, but we've got to work so much harder to extend the conversation and to think about the words that we choose when we describe what we need to do, but use lots of those existing communities and existing relationships to do that. I hope it was Holly that I remember correctly for that question.
Actually, I was going to refer to that, coming next to the question before we come to the end of the panel, was about community engagement. I mean, some of the stuff we're going to explore later on in the panels that we've got coming up, but there were questions about community engagement, communicating, translating material, and also reach in terms of geographical reach as well.
Just
sorry,
generally,
Patrick,
sorry.
Did you hear that?
Kerry, you go ahead.
Sorry, apologies for the next set of questions was around communication. Communication in terms of translating stuff into community languages, translating of material. There are 1 or 2 offers I can see of people offering their services. Of that they've done some stuff already. There's your work around community outreach, how you're going to engage, and also how you're going to engage nationally in where there's areas of large BAME communities as well.
Well, firstly, any offers of help on language translation and support, I'd really welcome, and we will hoover that up from this call. On local community outreach, I think one of the principles that we are trying to build the service on is to have as much happen at a local level as possible. That sitting in Westminster and Whitehall, we will not be very good at reaching out to local community organisations, but local authorities and local health and care systems will be much better than I will be or my central team will be. So we want to push as much out as possible to local authorities. That's one of the reasons why we've given them money. So £300 million the government granted to local authorities to build their own local test, trace and contain action plans. And I really think that this is the way that we will succeed in stamping out the virus, is through engagement with voluntary organisations, local community centres. I think there's quite a lot of work for us to do, as Kerry's saying, in terms of switching round our testing model, for example. I want to, think one of the things we're exploring at the moment is where in communities would be the best place for people to easily go and get a test. Is it a tent attached to your GP surgery, or is it actually in your local community centre? And I suspect those will be different choices for different communities across the country. So we need to give the local teams the permission to design their own model the best they can. That's the way we've got to shift. Now, clearly that's not easy to do, and it's much easier for me to say it than it is to actually do it. And as we've built this system, or are building it at such speed, sometimes we are doing stuff at a national level that we know over time we have to delegate down. And so there's, in the last 3 months, we've built a testing system nationally that is the same size as each of our online supermarkets' online delivery business. And unsurprisingly, because we've built it in 3 months, there's quite a lot of stuff that we can do to improve it. And one of that is by having more of it locally owned and led.
Yeah, just to come in here, if that's okay, Patrick and Dido.
Yeah.
Absolutely.
Yeah.
Sure.
Okay. So I just to agree with the importance of using local grassroots communities, because we're not a homogenous group. So even in my own Pakistani community, there are different dialects, there are different levels of engagement with services. We're also influenced by our jobs, professions, and social class. So the more locally the solutions are designed, the better outcomes we're likely to get. So really, let's focus on our differences and diversity.
Okay, that's great. We're going to come to enter the panel. We've got another hand up. Claude Henderson, you've got a question for the panel? Hi, Claude, are you there?
I am. Can you hear me?
Yeah, just keep on speaking.
I don't know if you can hear me, that's why.
Yeah,
okay,
we can hear you.
My question is two-tier. The Black community, the African Caribbean community doesn't have a lot of trust right now. So how are you going to get that trust back? And my second part of the question is, how are you going to encourage men, especially Black BAME men, to participate?
Okay, thanks for that. 2 questions. How are you going to build trust within the Black community? Obviously, I imagine you mentioned the context of Black Lives Matter and everything else that's happening. And secondly, in terms of how you're going to engage with BAME men.
It's a great question, and I actually would really like your advice, Claude, on what we could do that would start to build that trust. So what are the, I want you to know that the intention is absolutely there amongst our team, but we actually most need your advice on what are the actions that the service could take that would start to demonstrate we mean it.
Number one, you would need to ensure that you have Black, African, Caribbean people as your tracers, and that we can see people that we can relate to, that we know. And of course, ensure that there's some Black men as part of that team.
Okay. Very clear. And yes, we need to do that. And I'm sorry, I haven't got the statistic for the person who asked what the proportion of what the ethnic breakdown is amongst our ethnic colleagues in tracing, but we will share that with you. I think the data is there. I just haven't got it myself. Okay. And I totally get it about the need to have visible leaders from the Afro-Caribbean community, male visible leaders.
Okay. Thank you.
Thank you.
Okay, thanks. We're going to come to an end because I know that, Dido, you've got another meeting to go to. Any closing comments from all of you before we finish this part of the session?
Just want to say that I'm really pleased that Test and Trace wanted to be part of this webinar. In the informal conversations, I know there's a commitment. I just hope this dialogue continues. Prior to this meeting, I spoke to a group of equality, diversity and inclusion leads about test and trace. And there's a huge amount of expertise in the system already. So let's start by listening to the experts who are already in the system, who are able to help us with this. And let's continue the conversation, not just today, but for several weeks and months until we get this right.
I just want to say thank you for the conversation, the chat conversation, furiously scribbling those ideas, those thoughts down, and the honest feedback there. I'm going to hang on if that's okay, Patrick. I wanted to stay for all of it and take part,
Yes,
if that's all right.
You're going to be at the end of the programme anyway. Don't worry, Kerry. You're not going away that easily.
So I'm going to, no, I don't want to go. I'm here. But yeah, that was a really thoughtful conversation. So thank you.
And any final words from you, Dido?
I'm sorry I can't stay, but Johanna put it so beautifully. This is, for us, the beginning of a discussion and a conversation. We will follow up, and please can you keep the really honest and hard-hitting feedback coming, and the practical suggestions that are in the chat and have been on this call. It's hugely helpful. So thank you all very much indeed.
That's great. So thank you very much for all of being in the panel. We, as you know, we did a poll at the beginning of this event. We can actually review the results because I think some people have been still doing that. So my fantastic moderator, can you just share the latest in the voting? Okay, so as you can see, roughly, I imagine this is in percentage terms, 44% of people I've heard but still don't know much about it. We're going to ask that question again, by the way, because by the end of today, hopefully that figure will be much lower, or higher, I should say. And the next question, as you can see, more increase in how people think that it could help, this service can help to reduce or tackle COVID-19. Make note, Matt Hancock. And then in terms of the question of concerns, obviously, even more people are still a bit concerned about the whole stuff around sharing personal data and having the app on their phone as well. And that's something obviously that the organisation need to still address as a concern, which I'm seeing, which is probably a concern nationally, I imagine also as well. What we're going to do, everyone, we're going to have a 5-minute break. Then we are then going to have, two, for the rest of the afternoon, we're going to have 2 panel debates, which are going to go in a bit more detail around the service and how it relates to the wider issues around BAME, Black and North communities. So we'll have a 5-minute break, and we'll have the first panel. We'll look at technology and communication. We'll have Yvonne Field, Director of UBELE, Galab Khan, who's the founder and director of Written Medicine, and Asad Donar, Director of Unstaples. I'm not sure if we've got a musical interlude, but grab yourself a tea, coffee, hot water, and we'll be back in 5 minutes' time. And then thank you very much for everyone that's been part of the first panel of conversation today. So welcome back, everybody. We've covered some of the basics around the service. We're going to drill down a bit more about the implications of service around two key theme areas around technology communications and community response and engagement. I know there's lots of messages in the chat room, and just to let you know, we are going to be producing a report based on the feedback from today's session and the notes that you've put in the chat room as well. So don't worry if you've not felt that you've not had all the answers, questions heard. We will capture the feedback as well. We also, we are recording this, and so this will be available on the UBelay website, so you can actually watch in your own time as well. So we're going to move on to our next panel debate. This is going to look at the issues around technology and communications, and we've got Yvonne Field, Director of UBelay, Gilab Khan, Founder and Director of Written Medicine, and Asad Donar, Director of Unmistakable. I'd like to first invite Yvonne Field from UBelay to start.
Okay, good afternoon, everyone. I'm not sure if you can see me because I can't see myself on the screen. I can just see the UBelay logo.
We can see you, don't worry, Yvonne, we can see you.
Okay, fine. Okay, great. Yeah, well, you know, this was a difficult, probably one of the most challenging events that we've co-designed, because at the beginning of the COVID-19 outbreak, you know, we had lots of heated discussions about the idea of the testing program and what that would mean for, you know, for BAME communities. And it's been interesting being on the, you know, the first part of this event, listening to the comments and questions that are being raised. And these are comments and questions that we've heard over the last 10 to 12 weeks, and we've asked ourselves as well. However, we felt it was really important to open up a space for honest dialogue and to see if there was an opportunity really to kind of, yeah, engage the community in this kind of conversation, to see how we might respond to this initiative. As it's been said, it's a national initiative with a clear objective. However, it does, in some senses, kind of present us with a number of dilemmas and concerns and questions. And, you know, it's really weird, but last Saturday, I got a letter, and it was actually to take part in a COVID-19 testing research study by Imperial College London and by Ipsos Mori. So it asked me if I would actually contribute to the survey by actually taking a test. Sorry, my eye seems to be watering in the middle of this. And, you know, what was really interesting, the letter, you know, came in the standard sort of white envelope, standard, all the logos, and gave me a whole series of things I need to do to register. I kept it for the weekend and spoke to a few people about it, including my family. And then by Tuesday, I actually signed up. So I'm waiting for the test to arrive. But I was absolutely nervous, and many of the concerns that have been raised about what happens to the data, you know, privacy issues and so on, I've still got, but I'm actually prepared to do the test because I think it's really important for us to take some leadership around it and to see what happens as a result. So that's where I am with that. I think, I mean, I was struck by the comment by Gemma Smith about the tone and the use of the language at the moment within the system that's being built. I think there's a huge amount of work that needs to be done around how we communicate with our communities to build trust. And I don't think the system has got it right yet. I think if you're hunting down the virus, it feels like I'm being hunted. And that, as a Black woman with a history of being enslaved as Africans, it just immediately brings fear up for me about what's, you know, they're going to come after me, they're going to hunt me down, you know, they're going to incarcerate me. Those kind of things come to my mind. So I think we need to think very carefully about the language. Just a couple other things I wanted to say. In terms of workforce came up, a number of people in the workforce, and sorry, my eye is really burning, I'm not quite sure why. But actually, I'm really interested in who's being commissioned to provide the service, the parts of the service, who's in the supply chain. Are BAME organisations in the supply chain? Because we have great companies that can do communications, that can do digital software, that can support this initiative. And I think they also need to be brought into the supply chain, you know, and as subcontractors. And that's often not part of the conversation that we have in terms of building these new systems. And lastly, I wanted to say, in terms of communities, it's really important that communities are engaged, but as has been mentioned many times in this, in the chat, we need community organisations to be financially compensated. They are experts in their field, they know their communities. I know this will come up in the other panel, but we cannot just take for granted that we have this expansive knowledge about how to engage with communities, how to work with our communities, which is not valued as social capital and not valued as having a financial value to them. So I think we need to think about how do we resource our communities to do this work, and whether we can actually, perhaps as a part of a pilot, I know this thing is moving really fast, but can we have some test beds? Can we have some pilots in particular BAME communities run by BAME community organisations themselves? So there's different ways in which perhaps we can think about part of the rollout. Can we provide some specialist support with our communities, for our communities, led by us? Thank you.
Okay, thanks for that, Yvonne. I'm sure that'll be picked up again in parts of the Q&A. I'd like to invite Gilab Khan, founder and director of Written Medicine.
Hi, Patrick.
Hi there, how are you?
Thank you. Very well, thank you very much. Thank you for having me on. It's very good hearing from Ida earlier. It was a shame she couldn't stay and hear the conversation from itself. But I know Kerry's here, one of the team members. So I've been speaking to NHS England and NHS X and other NHS public health departments since March, before even the data that came out from BAME communities, because of my work of written medicine. So we provide accessible medication content to the NHS. And we started hearing of excess deaths within and those in critical care of ethnic minorities. And we approached them then about the right messaging and the right communications. And up to now, nothing's really happened. I mean, we see the messaging that's coming from the government on BAME channels, for example, like, Urdu or Hindi or Punjabi channels on TV, on Sky, that are in English, when it's a Urdu only or a Punjabi only channel. And, they've failed in really, the minor stuff that they could have got right, let alone getting this test and trace. Dido, however, I know is quite passionate on getting ethnic minorities involved and having the app and the service more accessible. She's spoken to me previously about it. I understand that the team is looking actively at resources on how they can make test and trace more accessible for the communities. But number one thing is the messaging. There's so much mistrust within the communities on how that public health report by Kevin Finton came out, and when the full details were released yesterday, and even then that everyone's questioning, was this a whitewashed report? There's poor handling around the comms. There's a lot of people within ethnic minority communities who are questioning, not just within ethnic minorities, but also within the general white community, about, how is my data going to be stored? Why is it stored for 20 years? And Dido did explain why. But sometimes these things can easily be quelled. So, for example, your data, your financial data in IKEA is stored for 25 years, but most people don't know that. So, with a bit of better comms and better communications, such information, such issues can be quelled quite easily.
Okay, thanks for that. And then finally, we've got Asad Donar, Director of the Unmistakable.
Thanks, Patrick, and thanks for inviting me on. So for anyone sat there thinking, what is the Unmistakable? We're a diversity consultancy that works to make diversity everyone's business. And over the last 2 years or so, we've been working with mainstream organisations to try and get to the nuanced position they need to get to underrepresented or minority audiences. Two reasons why. One is within business, marketing, communications, there is a dire lack of representation for many push and pull reasons. And the second is that I think there's a bigger opportunity. And if you talk to commercial companies, they are starting to wake up to the Muslim pound, the Black pound, the LGBT pound, all of the communities that were once minority and niche, but actually have such a large and powerful voice right now. And the topic was around communications and technology, and I wanted to share 3 observations that we've had around nuance or the lack thereof that we've seen in the COVID response and within Test and Trace. I think the first is that the use of technology is so varied, and if you look at older communities, if you look at the intersection between age and ethnicity, there's a real question around access, and has the system been designed to be used by all communities? So let's take my 73-year-old mother, for example. How does she get the right access, and how does she get the right support in the right languages at the right levels that have already been touched upon? I think that's a real misstep, and you can see in the letter that came out yesterday from the Commission's findings that cultural competency is lacking within the current approach, and that's exactly something that we need to change, because it's becoming deadly and it is dangerous. The second point is around language, and Yvonne touched on this. Some of the words that are being used aren't necessarily being thought about from different angles and different perspectives. So what do they mean? How can they be perceived? A lot of the time in the work that we're doing, we're brought in to try and repair some of that, which is good and fine, but it needs to be thought of from the beginning. And this whole idea of being inclusive by design has to start with important elements like language, which have a big impact in the way people feel included in something as important as the virus right now. And I think the third thing, and it may have been covered already, so excuse me if I bring up old territory, but it is around the term BAME. And actually, is it a help or hindrance right now? And I think this has come up time and time again. I'm not giving a new argument to anyone, but what we see within mainstream white communities is BAME becomes a catch-all for everything that isn't white. But within the BAME community itself, there is disparities within it. If you look at politics right now, Asian women versus black men, very different. But also the question around what do we understand the nuance within BAME? And I'll just give you an example to close. Is we've tracked the media sentiment over the last year to date of the term BAME, and we've looked at how often does the word BAME come up in media. And we saw, and it's over on our blog if you wanted to have a look, but we saw that there were about 150 to 200 articles a week using the term BAME. On average. Then lockdown happened and there was a dip because everyone swapped the term BAME for sourdough bread and toilet paper and panic. So people weren't talking about nuance. And then you started to hear the first reports about disproportionality. And at that point, the number of articles per week increased to near the 300 to 400 mark. So you saw a 100% increase. And with that became a mainstream awareness of BAME that you hadn't heard and seen before. You heard it on Channel 4 News. You heard it on all of the mainstream news outlets. But where we saw the real change and the real shift was after the murder of George Floyd, and BAME went to about 1,000 articles in a week. So 200 to 400 to 1,000. And we said, and the point that we're making is when people want to say black, they need to say black. They cannot say BAME because it's not getting to the nuance of specific communities. And I think that that is the challenge that we have right now, that this grouping of BAME as a communication term could be a real hindrance in actually understanding the true nuance of a group. And that's the kind of thing that we obsess over and pore over because we think it's important to be effective and to be truly inclusive by design.
Okay, thanks for that, all 3 of you. I've got 1 or 2 questions for you. I just want to pick on the point I said about BAME. Lots of messages about, do we need to use BAME? Can't we get rid of it? And the question for all of you is, what is if we were to get rid of BAME, what the alternative would be? And how does a system like the NHS then deal with us? Because the way the NHS works, it's like one size fits all, and
Exactly.
that applies to us as well. So let's start with you, Yvonne.
Look, I'm actually going to sidestep that question in terms of what do we replace it with, because I think there needs to be a national dialogue about that. You know, I come from an era when actually the term was black, and black was used as a political term to encompass everyone who experiences racism. I'm really not happy to use, you know, I'm really not happy to use the term BAME. I use it as a I suppose what's used in common parlance. I'm also not happy to use the term people of colour, which I know, you know, young activists use as well, because that was rejected by those of us who were in our 50s and 60s and 70s back in the day. So I think that the issue that I would want to sort of suggest is that actually we need to find ways to define ourselves as a way to having ourselves being defined by others. And I don't think we've actually stepped into that place. We tend to be quite reactive to terminology that's either imported or thrust upon us. And I think that it's time to have a dialogue about that, and for different groups maybe to claim their own, or certainly but definitely claim their own identities and descriptions, and make sure that they're used in the common vocabulary that's used in the UK and further afield. So it's not for me to define. I think we need to define ourselves, and I think we need to have that quite difficult and challenging conversation, because I know in the 70s and 80s they used the term black. There were some pretty heavy conversations that took place where that almost came to some sort of, I know people would walk out the room and all sorts of things would happen at the time.
Yeah, yes.
So I think, yeah, I'm not getting into that one.
Fair enough. So, nicely sidestepped.
Absolutely.
Yeah, Gilab.
I've got my reasons.
Yeah. Gilab, can you hear us? Yeah. What's your take?
I genuinely haven't given much thought on this question. I mean, previously, as people have said, you know, POC or people of color was used quite widely in America. It's still used quite widely over here. I think in the UK, we stopped using it until we started seeing it resurface on social media a couple of years ago. It used to be BME, then BAME as to include and, but I don't know what to replace it with. I haven't given it much thought. Maybe other people on this group who you can write in the Q&A what they think. But yeah, I'm lost at the moment.
Can I offer something?
Yeah, you go ahead.
Yeah. So I think there's so many intersects to this. So I think the term black is a political term for a lot of people, and people in the 70s and 80s who were Asian were often politically black, and in the way that they thought. And as time has moved on, I think exactly what Yvonne has said is we've allowed the other to characterize us, and BAME has become the catch-all to it. And I think someone said, is it unique to the UK? It is. When you look at the data, you see 14,000 mentions of BAME in the UK versus 1,000 in the US. The US use BIPOC, which is, I forget the B, but it's Indigenous People of Colour. Black Indigenous people of color, which again, it has its own issues, and everything does. I think there is a job to be done about allowing the term BAME to exist in some form, knowing that it's a category, but then taking on the work to break down that category. So personally, if someone says to me BAME, I say, can you tell me what you mean by BAME? Do you mean black, Asian, or other? Or do you mean, be specific, because you can't just put together lots of countries or continents together into one. So that's my first piece of advice. And the second piece of advice with it is look at where the reclamation lies. And you see it with the word queer. Queer has gone through lots of different stages and phases of what it means. Education's played a big role on that, but it's really moved on. And so, yeah, reclaim the term that you want to be known as.
Okay. The danger, yeah. There's lots of questions on that, and I think this is going to be an ongoing dialogue. Maybe you might want to have a national conference on BAME. Think about it.
Yeah, the BAME game.
BAME, or people majority colour, whatever. But there's some interesting feedback. I'm sure we're going to pick this up again. I'd like to thank all of you, and we're going to move on to the next panel. So thank you very much. Oh yeah, sorry about that. I jumped the gun there. Let's get back to the survey. Let's see if the awareness around the trace service is happening here. So let's have a look. So going back to the question, how should the NHS communicate with, I'm sorry, I have to use the word, BAME communities about test and trace. I'm sure there's a cure for that somewhere. I don't know, some medication. I don't know. We'll find it. And look, it's quite mixed actually. Community radio, national TV, social media platforms, other media, billboards as well. It's quite mixed. Second question. Okay, how should the NHS make the information about services accessible to, I say it, BAME communities? And I can see it's quite evenly spread here in terms of champions, community champions, adverts, materials, and materials translated, videos into community languages as well. Galab, I'm going to jump to you. I know that you've been working in this space, and you made some comments about NHS space, and it might be a generic question around the NHS. But how much money is spent, do you think, on this kind of stuff around meeting the needs of inverted commas BAME communities from your experience generally?
Around interpreting services or translations or
well,
marketing?
Just the whole, how the money is spent on targeting marketing. So
targeted very, very little. It's usually only when they see a specific promotion to do within ethnic minority communities will they spend money on translating or printing out leaflets and stuff. So for a good example would be organ donation. So recently organ donations now opt out rather than opt in, and they saw a very big backlash from the ethnic minority communities, again due to the mistrust of previous experiences, probably from back home. There's a lot of organ theft and problematic area when it comes to organ transplants in a lot of third world countries or developing countries. In the UK, it's not so much so, but that mentality still carries in. And only then did they decide to put some resources financially towards it. Interpreting and translation services, I think roughly £100 million is spent a year on average in the UK across the NHS. So secondary care, acute, mental health, primary care.
Okay, thanks. I do know, I mean, you work in the kind of media brand world. What's your take on what you've just seen there?
I think I'm looking at that going, why are we putting BAME into one group, and actually which group out of that set needs more? Because I think that's where there's a real difference. And I think also with if I think about my mum's generation who have been so overlooked by communications, she's going to listen to other Asian women. So she's not going to listen to BAME people, she's going to listen to that. And that's, I look at that and go, I don't know if we've got the data. And I think someone's flagged that in the questions to go, we need to be drilling it down further.
Okay. So I suppose the question for today's event is, how do we influence this brand new NHS service to make sure that we can learn from the past and get the communication right and nuanced as well?
Nuance, yeah. I think nuance is the key word I would take away.
Okay, great. So on that note, I'd like to thank you very much for being on the panel. And we're now going to go to our next panel, which is Karim Alim, Director of the Council of Somali Organisations, Michael Hamilton, who's Programme Director from Ubele, and Jake Ferguson, who's Director of Hackney CVS. So hopefully all of you should be ready. I'd like to first invite, I don't know if we've got Kahim?
Patrick, it's Kahir.
Kahir, sorry Kahir, sorry about Kahir. Hi Kahir, welcome.
Thank you very much. Thank you for inviting me. I'm the director of the Council of Somali Organisations. Just to give you a bit of an idea of what we do, basically we are one of the only, I think, uniquely placed secondary tier umbrella organisations representing Somali voluntary and community sector, offering culturally appropriate support. We have about over 100 plus membership, and where we support the community organizations in terms of core areas of health, well-being, criminal justice, education, poverty reduction, and economic empowerment. And our mission is literally to influence, advocate for the Somali community and strengthening the Somali voluntary and community sector, build bridges with other sectors and other communities, and influence national and local policies through our membership. Now, I think one of the things in terms of track and trace, and in general, NHS services, and in other policy areas. It's always been said that the Somalis are one of the hard to reach communities. Now, just to give you an idea of the numbers of Somalis in the UK, there are about between 350,000 to 500,000 people of Somali origin in the UK. And that's grown since the 2011 census, which showed there was only about 180,000 who identified themselves as Somali-born migrants. So it doesn't capture those born in the UK, but those who arrived in the UK after that date. Now, a lot of research says that Somalis are disengaged or marginalized from mainstream society. And there are a lot of factors that are involved in terms of that. And I think there have been a lot of studies which show that Somalis may be impregnable, words like uncommunicative and hard to reach. In all honesty, we are not hard to reach, but I think that we have particular issues associated with our community. And obviously this derived from the fact that we have different waves of migration. Somalis are not new to the UK. Somalis arrived in the UK over 200 years ago as merchant shipping in the British Empire, and they've settled in places like Cardiff and Liverpool. Now, it's only, I think, when you look at the other migration streams that you tend to find that the difficulties with accessing mainstream services. And what you'll find is the older generation arrived with experience of trauma from the Civil War, and having arrived through complex, difficult journeys into exile, who are in some ways, living the myth of the return in some ways, and they live here, but they don't live here. Then you have, issues arising from forced migration in terms of family breakdowns, deprivation, social exclusion, and high level of female-headed households. And in relation to young Somalis, I think those who are born, we have a huge intergenerational and dual cultural tensions. And, in terms of a lot of the issues that arise from young people, we have a disproportionate number of young people in the criminal justice system. So, we have a lot of factors in relation to young people. In general, I think there's a lot of climate of suspicion from Somalis, given the history of the Civil War and issues like, stop and search and association with, terrorism and, prevent and gun knife, and knife crime. Now, what I would say in terms of track and trace is that there are issues in terms of the way the data is held. And I think because the government has decided to basically go for a more centralized data collection, people with refugee backgrounds are always going to be suspicious of their data being held. And we found that in terms of the work that we have done with the ONS in relation to the upcoming census, that it's not so much as the younger population and the young Somalis, but is the older population and the recent migrants who are deeply suspicious of data and the big brother issue of data being held. And I think this is common with a lot of refugee communities, and also common in relation to, people not, coming from, civil war and police states. So that is my contribution to that. I think one of the things people need to think about when they're trying to reach communities like the Somali communities is that, how the data is held. And that is a big issue.
Thank you very much for your contribution there. And the history, which is often people always forget about the Somali community as well. I just want to invite Michael Hamilton from Ubele.
Hello, Patrick.
Hi there, Michael.
You're hearing me? Yeah, sorry, Patrick.
Well.
I've been kind of listening. I was kind of started listening, thinking, what am I going to say? What am I going to say? What am I going to say? What's track and trace? How does it work? What does it mean to us? But kind of as I've listened, I've kind of actually got quite engaged in the conversation about what we call ourselves and the importance of what and how we call ourselves. Yeah, and then kind of been mixing that in my head with the ideas about us being hard to reach. And it's kind of had me saying, well, what does hard to reach mean? How does something become hard to reach? And I we kind of hard to reach. I don't think people are hard to reach. We know where they are. We know what languages they speak. We know what shops they go to. We know which doctors they go to. We know which schools they go to. And so people aren't hard to reach. They're actually quite easy to reach because most people in this country are very, very visible. But what they might be is hard to engage. And for me, if we kind of use the word engage rather than reach, it starts giving us a clue about what in the relationship between people I call black people, some people call BAME people, other people call people of color. But it begins to give us a clue as to kind of what is happening in the relationship between us and them that is making it difficult for them to have conversations with us that we trust. And the sorts of things that are going on between us and them is that you'll know more about this than many people, that they're treating us as if we're in a kind of hostile environment. They've created a hostile environment to deal with us. We know that they are treating our children badly. We know that they are treating our adults badly. We know that all sorts of things are going on for black people in this community that makes it hard for us to engage with the people who are doing those things to us, you know? And so where it comes back to me to what do we call ourselves, I think that we call ourselves something which is not about our ethnicity, which is if we are Somali or we're Jamaican or we're African or we're Caribbean or we're American or English or Canadian or something, but the thing that unites us is our experiences in that relationship, in living in this country. And so I think that it becomes quite important what we call ourselves, because if we start calling ourselves just in terms of our ethnicity, what we do is that we miss the problem of the relationship that we have with power in this country. And we then go on to allow people to talk to us as if we have an ethnic problem or a problem that makes us particularly hard to reach or particularly difficult to talk to because we have some kind of genetic problem of understanding. We don't. What we have is that we have to survive with the kind of racism of this country, and that the nature of that racism makes it hard for us to engage with people who are racists.
Okay, thanks so much, Michael, for your philosophical analysis there. I'm sure we can pick up on that a bit later. I just want to invite Jake Ferguson, Director of Hackney CVS.
Thanks, Patrick, and thanks to you and Yvonne for inviting me to come and join the panel. Really interesting conversation. Sorry I haven't been involved in the since 3, so yeah. The things I might say may have already been said, but I'm not going to talk about definitions. I don't feel I've necessarily got enough experience to talk about, and there are others on this call that can speak more eloquently. What I did think would be useful for me to share, Patrick, was some of the work that's going on in City and Hackney.
Sure.
So for those that are listening, my name's Jake Ferguson. I'm the Chief Exec of Hackney CVS, which is the umbrella body for local charities and community groups in Hackney. As you would imagine, we've got a very large sector, over 1,500 organisations locally, and a large proportion of them represent our different diverse communities. Diverse communities is a new term we're using at Hackney CVS rather than using BAME or black and ethnic minorities. It doesn't solve the problem, but what it doesn't do is to lump everyone in a homogeneous group. So some of you may know that Hackney, alongside Camden and others, are pilot areas for Test and Trace. As such, the Public Health Department in Hackney, City in Hackney, found out last week they've been given £3 million to help with the rollout of Test and Trace. It's a hell of a lot of money. We've been talking to Public Health before we knew that there was resources available, just wanted to add that point, because they reached out to us, and our Public Health Department very much realised they needed to engage with communities in order to overcome some of the issues that you have all raised today about mistrust, stigma, what's going to happen to the data, and we don't feel any differently to you about some of those concerns. We talked to our staff, we talked to the local sector, and we've since sent our concerns to Public Health. However, we also realise that without a vaccine, Test and Trace is one of the most important mechanisms we've got, whether we trust it or not, to protect our communities. So we've taken the decision, we want to engage with it. We don't necessarily endorse a centralised system, but we need to work with what we've got. So we've been working with the Public Health team to effectively create a grant programme locally that local groups will be able to apply for funding to help with an aspect of the rollout. So, I mean, Yvonne talks about, can money be given directly to Black and ethnic minority groups to lead on this? Well, we're trying to facilitate that in City and Hackney. So grants will be available to, for instance, for communities to hold their own workshop or similar Zoom type call to this, to talk about the issues, to help create an army of volunteers that can work and either are already embedded in communities or can be connected with communities to help explain what it's all about. Public Health are going to do videos with us to explain things in sort of human terms. I think that's been really helpful to allay fears when the Director of Public Health has come on to our Zoom calls, where we've had 100 people on the call, to actually talk about what it means in real terms, because it's all right seeing it on paper, but when you hear it from another human who you trust, you're more likely to then respond to it. She's also explained about the script about Test and Trace, and Test and Trace call handlers are trained in how to engage with communities and how to help people trust. So I'm not saying it's by any means a perfect scenario, it isn't, but from all accounts from Public Health, they seemed assured at the quality of the people on those calls. However, we know that a third of people thus far haven't engaged when they've been contacted or they've had a positive test. One of the ways around this issue about trust we've talked about locally is that if you test positive, you'll be called and asked to give the details of anybody you've come into contact with in the last 2 weeks. Now, most of us would have an issue with that. I might not be too comfortable about giving my friend's number that I met over the weekend for a quick drink in the park. So one of the ways around it is that people will be given a letter that they can then hand over to people that they've come into contact with. So it feels less like a centralised approach and more that the onus is on the person who's tested positive to then contact people rather than that be through a national system. That might mean that a few more people have more confidence because they're getting it from somebody they know, or even if you were a stranger, at least you've had some contact. So that's one way around. It won't solve all the issues, but it's one thing that we're considering. What we're really keen to do with potential investment from Public Health is to actually demonstrate the value that local community organisations play, generally speaking, about echoing messages and helping to reach all our different wonderful communities in the borough. So I'm going to be using this opportunity to work with Public Health to really demonstrate the value of a community-led approach. We aren't at the process of launching the grants yet. We will be doing in the next month, we think. We have issued information in our newsletter today and yesterday. Another important part of this conversation is also about how community organisations that are now going to be reopening or starting to think about reopening to the public, is how they can get support from environmental health in the council, because there's lots of guidance now available for businesses about how you reopen safely. And we're starting to talk to public health about, can money be available to buy additional cleaning routines, to buy additional PPE for community groups that are perhaps not meeting the threshold for PPE. And I think that's an important part of our safety net. I'll probably stop there because I've talked enough, but I'm happy to take any questions. I think what we have is a very proactive public health department, and I think it will vary across the country. But if you haven't already, I would suggest you make contact with your public health team and say, look, what's going on in City and Hackney is really interesting, because they're going to be resourcing community groups to be part of the offer. And I think everyone should be doing that, frankly, not just Hackney. So I'll stop there, Patrick. I've probably said enough.
No problem at all. That's fine. That's very useful, Jake. So I think anyone, if you've got any questions, please either put something in the chat room or indicate, and we can ask the question directly to the panel. I've got a question for all three of you. As you know, you've heard Jake might have missed part of the conversation, but some of the conversation has been about investment in community organisations. This has been a long and historic conversation around a whole range of healthcare, public health interventions, social interventions, and then also a lot of money has been given out over the last few months around COVID-19 to the voluntary sector. Do you think what else is required, either for this service, which is obviously part of the wider NHS offer, to invest more in voluntary community organisations to deliver either health messages or interventions, or just having the resources just to engage with communities as well? Let's start with you first, Michael.
I suppose the first thing that that I've been noticing in this, Patrick, is a kind of maybe I'm not sure what to call it, but a kind of over professionalization of community services, and that people having to jump through hoops that most small community projects should never have to jump through. I know that my mum goes to a cake making group in her church on a Thursday, that they've had particular problems with kind of just paying some of the money that they pay to somebody to open up the door and close the door for them on a Thursday night, and whatever contribution they make to the church. And at that level, I think there's a lot of kind of very small Black organizations that need very small amounts of money just because they've had no income in the past 3 months. But even those organizations are being asked to have trustees and accounts for 2 years and all sorts of things that they would never, ever, ever have thought of having, and probably never need in order to kind of continue the small services that they run. And so I think there's a need for just kind of some small amounts of money for small organizations that can prove they have some track record of activity to kind of continue with that activity. In terms of track and trace, and voluntary organizations, I'm sure that there's lots of voluntary organizations out there that could be doing this work. I'm sure that we only need to look at the work that was done by voluntary organizations, and particularly Black voluntary organizations around HIV in our community, to see that the health expertise is there, and the ability to get out there and to make real contact with communities is there as well. Yeah.
Okay, I think, Jake, you wanted to come in there.
Yeah, so Patrick, you're interested in how this can become more commonplace. The reality is, I think what happens is we get national schemes developed, and if we're lucky, the voluntary sector gets mentioned. If we're really, really lucky, and it's a rare occurrence, there actually will be a section on the how. And I think it's the how that's always the issue for me. Is people might have good intent to engage with the wider voluntary and community sector or particular communities, but they don't give much thought to the how. And I think if we focused on the how, then that would address some of the issues that Michael and others are raising about, you know, what's the best way of engaging community organisations when, you know, largely speaking, they don't want to always become these hugely professionalised institutions. They just want to carry on doing the good work they're doing. So it's for me, it's what comes first. If that's the nature of the sector that we are working within, don't try and change it, work with it, and the centre needs to change to fit rather than the other way around. And I think that for me is a fundamental question and conversation we need to have in the current context of all that's happened around COVID and Black Lives Matter. So what I often find, because I regularly sit around the table with leading health professionals, government officials, and I find that they don't put the time in to working out how is this going to land and engage communities. If they did, we all collectively would be in a much better place, and we would also be valued more, and organisations like UBELI and other national or regional Black and ethnic minority representative organisations would be automatically invited to the conversation because they would see you as helping to understand how that implementation happened. I think CVSs more broadly have a role to play in that we are regularly engaging with our sector and know all these challenges to getting people part of delivery pathways. So I think if there's anything that we need to do collectively, it's to say strongly to government, involve us at the start of your thinking, and therefore the implementation will be a lot easier to manage.
Okay, thank you. And Father Karen, you want to come in there?
Yes, please. I think I'm going to give two examples of recent work that we've been involved. One is in relation to a big national charity who approached us and said, look, we want to work with your members, but this is like a 9-page document, and can you say, you know, who's interested? And we had a conversation as to what they meant by that. And I said, well, first of all, you got to condense that into 1 or 2 pages so that, you know, it doesn't become like, you know, onerous to understand, first of all, what you want. But secondly, also to, you know, say, look, you got this money from, you know, the government or whoever, and obviously, you know, you have to, you know, tell us what you're going to pay. The other was a different one where we approached a public health authority and an NHS trust and said, look, we want to apply funding with you to co-design a program for health in a London borough and on a grassroots level. And we're going to use that to strengthen the organization's capacity to engage with the public health, and for you to understand these organizations, plus to be able to deliver through them. So those are the two kind of approaches. When I looked, I thought, you know, which one would work? You know, I think, you know, I think my money would be on the latter one.
Okay, great, thanks for that. In the chat, I've noticed there's lots of examples of people raising about different communities of interest. So people raise issues, what about the Polish community? What about the Gypsy Traveller community and other communities? What's your response? I mean, if we're not going to use the word BAME, for example, or if we are going to use the word BAME, how are we going to ensure that certain community groups and organisations are engaged and maybe even get paid to deliver some aspects of the work? Anyone, you want to comment on that? Yes?
I think it all goes back to the issue of the way resources are allocated using the data from the census. And obviously, you know, you know, when you look at the Eastern European migration patterns, you know, 2004, and then, you know, later on the others joining, you know, so, you know, you can see that, you know, it's just not just BME communities, but other communities also. And how do you, you know, say, you know, if you're allocating resources using the data from the census, and if there's more flexibility in that, then obviously, you know, and also the more of the local authorities being able to collect more data in terms of identifying who lives in their areas, I think that might be a starting point.
Okay, that's great. Any comments from yourself regarding that? If not, what I'd like to do, that's one more question, and then we're going to come towards the close of the proceedings. And I suppose the question is, in the light of, now we know that the full public health reports come out around the impact of COVID-19 done by Kevin Fenton, Black Lives Matter. Do you think this is now, can you see things changing for the better or not at all in terms of how communities of and a whole variety of minority ethnic communities will be taken either seriously or not in terms of engagement and resources, and particularly in light of Boris Johnson's recent announcement of this Commission of Racial Inequality?
Can I come in, Patrick?
Yeah, sure.
So I think I haven't read all of the public health report. I've skim read it and read the executive summary. I think it proves the point I mentioned earlier, in that it says some nice things, and it certainly does talk about the need to co-produce with black and ethnic minority communities, but it doesn't necessarily talk about the how. And I think now is an opportunity for those on this call, a collective of organisations, to say, look, we will work with you, public health, to help you understand the how bit, because the how bit is so key. And within that, that's when you can be talking, or we can be talking about the need for sustainable funding, the need to create, to build on the assets and fantastic networks that already exist, rather than to think anything new needs to be dreamt up. So I think we should seize this opportunity to say to public health, and Kevin Fenton particularly, to say, look, we can work with you on a rollout of the recommendations. Because if you just let local authorities roll it out, or public health departments, it will only give you half of the picture. You know, and as that goes further down the power structure, it'll get filtered down to the point when it's virtually not indistinguishable from something that would be all population focused. So I think that there is an opportunity to set out what we think collectively needs to happen in response to that. And the other thing I'd say is that there is a need for much longer term funding for the black and ethnic minority voluntary sector as a whole. I'm involved in some very, very early conversations, which I've been having a bit with Yvonne and Ubeli and some others, about could we create our own foundation or endowment for black and ethnic minority communities, which would allow a sustainable long-term pot of funding to be there to deal with such crises in the future, and also to encourage other funders to do more in this space. So I think now is the time to actually be really quite ambitious and to undo the wrongs of decades and decades of disinvestment and undervaluing the black and ethnic minority sector.
Okay, fine. Any comments from the panel members? You don't have to.
Can I say, I think this is a unique opportunity in terms of the level of engagement. And I think there's been so many different recommendations from various different reviews. I don't see why we have to accept the offer of another review or another commission until the government responds to even, the Windrush review, or, the David Lammy review, or any of the reviews. I think once maybe we can see some action in terms of, in terms of those, where those have gone, what are we, it just seems a bit like, kicking into the long grass. But also in sense, I think in general society, I think there's an understanding of what race is. And there's now space to talk about the inequalities, and especially that affect different communities. And I think this is a good opportunity to advance and be ambitious, as Jake said, in terms of making demands, in terms of long-term core funding for, BME community organizations. But those are the ones that are going to sustain. I mean, COVID-19 was a bit like the earthquake, but there's a tsunami coming, of a recession. And whereas the government spent a lot of money, trying to mitigate the effect of COVID-19. So where's the money going to come to fund communities in terms of after the recession, and in terms of long-term community sustainability and resilience?
Yeah, thanks for that. Finally, Michael.
Yeah, I suppose just two small things, Patrick. One, I suppose, is about the government and what we can expect from this government. I think it's W.C. Fields that said, if you can't baffle them with your brilliance, befuffle them with bull. And I think that this government has shown that they're not brilliant. And what they've done is that they've lied and they've given us a lot of bull, and that they've baffled their way through 2 elections and won, and thought that they might baffle their way through a fight with the virus. And it kind of looks like the virus is winning at the moment. And that what they've done with the PHE report, I think, is that they have pulled bits out of that report, and then they've thrown a little hand grenade of, I've forgotten what her name is, the woman who they've selected to run their kind of race commission. They've thrown a little hand grenade in there in order to just kind of befuddle everybody and to get everybody talking about other things. I think the important thing, though, to remember, Patrick, and David I'd never know David's name, the historian on telly with
Olusogo.
David Olusogo, I think, showed us in his program on Monday that racism and what is happening to us now is not incidental. It is not an accident of history. It is a series of purposeful actions which are designed to impact on us in a particular kind of way. In David's program on Monday, he showed government papers which were talking about Black people and what they needed to do to stop Black people coming into this country in those terms. Yeah, and so racism is not accidental. And so I think that we need to be really careful in the voluntary sector that we don't become the gatekeepers to protect the state from the anger of everybody else. And we need to be very, very purposeful in our relationship with them. And should we choose to hand their money out on their behalf, we have to be very, very purposeful, because I think that there are real dangers.
Well, on that note, thank you much for that, for the panel. We're coming to the end of today's session. We're going back to the poll again to see whether there's been a shift in attitudes and perceptions and knowledge sharing. So the question here is, what more you like, what additional information, what more you like, and so look at that. Highest number is about the service as a whole. That's important. And what happens to personal data? Again, still a big issue with that as well. And the other question that we've got is, what would you like to do with information that you've heard? And in this regard, again, we've got lots of responses in terms of sharing to wider inverted commas BAME community, and then share with other non-BAME community as well. So as I said before, we are going to be producing a kind of conference report, some report of all the key issues that's been raised as well, which obviously we want to share with, particularly with senior officials in the NHS Test and Trace service. I want to invite Kerry Edwards, who is going to give her reflections on what she's heard today. Kerry Edwards, are you still here with us?
I am. Hopefully you can hear me, Patrick.
Yes.
Fantastic. I feel a little bit overwhelmed and humbled by it all, to be honest. The chat conversation has been incredibly meaningful alongside the voice-led presentations today. And I've tried to capture some offers of support. I know some people have reached out there to say that we can work together, and I'll make sure that we reach back out. overall, for the Test and Trace organisation, there are 6 really big themes for us from this, Patrick, that we will take back, and I'll make a commitment to think about how we keep each other up to date and rejoin the conversation. Those 6 themes are the workforce representation from a leadership perspective, but also all the way through to, I think it was Claude who talked to us about how do we reach out to certain members of Black men. I think Claude uses an example whereby using actual people that represent those communities in the Trace team. So workforce representation, one theme. How we make sure we've got trusted partners. There was a lot of questions and concerns about some of the partners that we've chosen and how we engage with making sure we all believe they're part of a trusted network. The third theme is around the local ecosystem, and that's massive. I've got pages of notes on that in terms of how do we financially support and then link in with the grassroots organisations that really will make this tick. Fourth theme is around accessible help, so translation, translators, and how we think about the communication style that we use. Fifth theme is around privacy. We've just come back round to it again. So what data do we need? Why do we need it? Where is it held and how long for and why? And I think we just need to be really transparent with that. You know, the trust of this organisation is the most important thing. So we need to just build that trust by sharing with you what we're doing. And then lastly, engagement was the last theme. The words we use, I've kind of having it played back to us and hearing Yvonne talk about feeling hunted and tracked. I think somebody used the word warlike. I just think there's something we can really think about together there and think about why they matter and what would we rather use instead. And lastly, I just want to recognise and share with you a conversation I had last week with a colleague who we'd found a report of somebody talking about the hard to reach communities, and we were having a conversation about it, and a colleague of mine pulled me up and said they're not hard to reach, you're not listening, they're just seldom heard. And I think somebody used that comment in the chat today, Patrick, and it's really struck a chord with me, and I know all of my team, and so I just wanted to share that and say that for us that means proper engagement and building the trust in the conversation. So that's my takeout. I hope that's tried to summarise it neatly with just a few seconds left of the call. And lastly, just to say thank you very much for letting me join you today.
Okay, thank you very much. And also I want to thank everyone that's contributed to this event, all the speakers. So I want to thank everyone. And also I want to acknowledge obviously the senior team of NHS Contract and Taste service, because obviously they want to make a better service. Our job now, I think, for everyone is how do we build on this conversation. It's a start of a dialogue, and we need to make this service work, because as we all know, that COVID-19 has had a major disproportionate impact on our communities. And if there is going to be a second pandemic, then this service is going to be even more critical, and we need to get this right. So on behalf of the UBELE team, thank you very much for participating in the event. There will be a report that will be shared. There'll be a video that you can watch in your own time as well. And I'd like to thank everyone for participating in this event and start a dialogue so we can get things right regarding the service. I'm Patrick Vernon, and it's great. And we've got about 111 people still with us, and that's fantastic. I mean, I think there's been fantastic quality conversations and really positive suggestions and recommendations in the chat and just generally speaking, and we're just going to take it forward. And this is part of a series of events that UBELE has been organising around COVID-19, and the word is deliberate: emergency conversations. As we know, it's an emergency and we have to be proactive and make things happen. So thank you very much. And as normally I'd say, get a safe journey home, but you're home already, so I don't need to say that. So thank you very much, and watch out for the feedback from the event. Thank you very much.
Thank you, Patrick.